request Dr. Azra Ahsan for WHO LCG, the next generation Partograph. Thank you, Dr. Azra. Please come.
Thank you. And before we talk about the LCG, Dr. Mariam was talking about Bakhabar Naujawan. I just want to tell you, use it as a counseling tool in your clinics. For example, when my patients come and I tell them, aapka pap smear karenge, and they have no clue what a pap smear is, and you don't have time in your clinic to explain it to them, give link to this course. They will not only know what pap smear is, but the fact that it needs to be repeated and that there is a vaccination, all this information they can gather from Bakhabar Naujawan. So why do we need to talk about labor care guide? And in your bags you have a page of the labor care guide. And why do we need to switch from the partogram? That partogram is there, a lot of people still have it in their files. Why do we need to switch it? It is because in 2018, WHO made intrapartum recommendations. There were 26 new recommendations, 30 existing recommendations, and it started from labor onset through to immediate postnatal period. It is for healthy babies and women and babies, and it is any healthcare setting, from a basic health unit to a tertiary care teaching hospital. So, what are the guiding principles for this intrapartum care model? Is that the care should be individualized. One care fits all is not correct. And it should be woman-centered care. Normally in our healthcare settings, what happens that the care suits our convenience. So we are trying to accommodate our convenience to our patients. And there should not be, just because the woman is in a hospital, it does not mean that there should be interventions which are not really medically indicated. And only those indications should be done which have proven to be clearly beneficial. And the woman should, in the end, have a positive childbirth experience because of how we take care of her. So if you look at this blue circle, this is about essential physical resources and competent and motivated staff. Okay. So this is a wheel which tells you about how to give this care in a respectful manner to the woman. It's there on the WHO website and it's excellent. So WHO recommendations on intrapartum care for a positive childbirth experiences, and this labor care guide, the next generation Partograph, I'll tell you briefly about it. This is the old Partograph, and this is the labor care guide. What is the difference between the two? You can see these are lines, the action line and the alert line. It's missing here in the labor care guide because now there is a column here, which is an alert column. If you look on the papers that you have, it's this one. It's from top to bottom. It's an alert column instead of, and I'll tell you why we don't have a line anymore, because the active labor, previously we believed that the woman should progress at 1 centimeter per hour after 4 centimeters, but all that has drastically changed. So the active labor now starts at 5 centimeters, and in fact, in some studies, even after 6 centimeters. And for it does not, the labor is not expected to progress at 1 centimeter per hour. So that is one reason for it changing. And the labor care guide additionally has monitoring during the second stage of labor also, which it didn't have in the previous Partograph. So what are the aims of the labor care guide? It guides about the monitoring and documentation. We not only monitor, but we document on this paper. And it offers supportive care which is the respectful maternity care, which element was totally missing in the previous Partogram. And it assists health personnel to promptly identify and address emerging labor complications. So you make quick diagnosis, and if referrals are required or any interventions are required, you can intervene quickly. It prevents unnecessary use of interventions, and it supports audit and quality improvement if you look back at your labor care guide and how women have fared under your care. So who should we do it for? It is designed for the care of women and their babies during labor and birth, all pregnant women, regardless of their status. So, if you think they're low-risk women and you think it is not required, that's not true. And we all know labor can change immediately, the snap of a finger, from a very low-risk pregnancy to a very high-risk situation. And so documentation of this should be initiated when the woman starts active labor, which is now 5 centimeters or more. So before that, you do monitor the woman, you do record your findings, but not on the labor care guide. You start putting your observations on the labor care guide after the woman is 5 centimeters dilated. So we've said at all levels of healthcare. So it has 7 sections. The labor care guide has 7 sections, which are section 1, like the previous one, identifying information and labor characteristics, name, etc. Number 2 is a section on supportive care, which was not present in the previous Partogram. Care of the baby as previously, care of the woman as previously, labor progress as previously, but with some difference. And then the medications given, and based on all this information, a shared decision making, which is not only between the healthcare providers, but also between the woman and the healthcare providers. So let's start one by one. Is the first section, which is identifying information and labor characteristics at admission. And you can see it gives, there's a place for name, parity, labor onset, active labor diagnosis and date, ruptured membranes if they are ruptured, and then time of rupture and if there are any risk factors. So that is section 1. Section 2 is about supportive care. And this section, which is all about respectful maternity care. Unfortunately, we do not pay a lot of attention to this component of care for laboring women. And with this respectful maternity care or supportive care, it includes whether there is a companion or not, whether there is something you're doing for the pain relief. It doesn't have to be an epidural or a medication. There are many other ways that pain can be alleviated. And whether there is whether she's taking oral fluids or not, what is her posture? Is she lying in her bed supine? And you can see in the column against them, there is N, 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 and P. So this is the alert line. If she does not have a companion, it's an alert situation. If she is not taking, there is no pain relief organized for her, that's an alert situation. If she's not taking oral fluids, and normally what happens as soon as the woman comes in labor, we put on a cannula and start IV fluids, keep her NPO. That should not happen. When we put on IV fluids, you restrict her to bed. And she likely to lie in bed in a supine position. And we know what that does to the baby, to a laboring woman. So if all these are a no, it is an alert situation. You have to do corrective measures for it. And posture, if she's lying in a supine posture, that is also an alert situation. And above it, you can see there is time. So the actual time and the hours that has passed since she said she was in active labor. So if it is 9 o'clock, she was 5 centimeters, and at 10 o'clock, it is 1 hour, and the time is 10 p.m. The section 3 is about monitoring the baby. And what are the columns in it? It is baseline heart rate, which is what will alert you if it is less than 110 or more than 160. Fetal heart rate deceleration, if it is present and it is a late deceleration, that should alert you. If there is, what is the color of amniotic fluid? If there is meconium or blood, that should alert you. And there is fetal position, if it is occipito-posterior, occipito-transverse, that should alert you. And all this abbreviations, the key is at the bottom of your labor care guide. Caput, if it is 3+, if it is a big caput, that should alert you, not small or medium. But unfortunately, there are no clear-cut cut-off levels that tells you this is 1+, this is 2+, this is 3+. That is all subjective and comes with experience. Then there is a column for molding. So a 3+ molding should alert you. And for molding, there are definite, ways how you can measure. So this is molding. If the bones are separate, this is 0 molding. If the bones are touching each other on a suture line, then it is +1 molding. If they overlap, like this is the green, darker green shade, they are overlapping, but they are reducible, that is +2 molding. And if the bones are so much overlapped and they are not reducible, it is 3+ molding. So next we come to the care of the woman. And what are we looking for in care of the woman is pulse. And you can see the alert. If it is less than 60 or more than 120, that is an alert. Systolic blood pressure less than 80, more than 140 is an alert. Diastolic equal or more than 90 is an alert. Temperature less than 35 or more than 37.5 is an alert. And every time the woman passes urine, you should check it for protein and acetones. And if there is 2+ protein or 2+ acetone, that's an alert also. So what does acetone mean? It means that your woman is dehydrated. And so she's acidotic, and if she has, that will lead to fetal distress. So that should be an alert as far as the woman is concerned during labor. Now let's see what has changed in labor progress. And that is what has really changed. मेरा मुझे एक प्लीज़ ये कागज़ दे दो, इसमें ये बहुत छोटा है और मुझे नज़र नहीं आ रहा ये लेबर केयर गाइड का पेपर वर्जन. So you can see first on the top is contractions. Thank you. First is contractions per 10 minutes. So if the contractions is 2 or less or more than 5 in 10 minutes, then that's an alert. Either she is hypercontracting or she's not contracting adequately. And if the duration of contractions is less than 20 or if it is more than 60, that is an alert situation as well. Now labor progress has 2 components, dilatation of the cervix and descent of the presenting part. So over here you can see, because the active labor starts at 5 centimeters, so here it's 5, 6, 7, 8, 9 and 10. So if she is at 5 centimeters, it is an alert situation if she stays at 5 centimeters for more than 6 hours. So it's okay for her to be at 5 centimeters till 6 hours if all the other parameters are fine. It is not 1 hour anymore. Okay, and if she is 6 centimeters, it's okay to be at 6 centimeters till about 5 hours. And at 7 centimeters at about 3 hours, for about 3 hours, 8 centimeters for about 2.5 hours, 9 centimeters for about 2 hours. And at 10 centimeters, again, that's covered in the second stage. So it is no longer 1 centimeter per hour. You're allowed a lot more time, provided the mother and the baby are fine. Then we come to the descent of the presenting part. And descent is, please understand, it's not by a vaginal examination. Sometimes we are deceived by thinking that the head is well engaged and it's coming out. We even apply, forceps or vacuum, and it's actually a big caput that you see, and when you feel the tummy, the head is, it's felt, quite a bit of it is felt in the abdomen. So it's a combined assessment, but it's mostly by an abdominal assessment, at how much head is palpable. So it's a 0, 1, 2, 3, 4, 5. So you divide the heads into 5 transverse components. And if the whole head is palpable, it is 5 by 5. And you would mark it here. Here, you put a dot here. And if it's 3 by 5 palpable, you put it here. And if none of the head is palpable per abdomen, you mark here. So just to explain that a bit nicely, this is the pelvic brim, this is the pelvic cavity, this is the abdomen. So this is the head which is totally palpable in the abdomen. It is 5 by 5 palpable, and you would put a dot on the line which says 5. And that is how 4/5 head, 3/5, 2/5, 1/5, 0/5, it is according to the fifth of the head that you can palpate through the abdomen. In the 6th section, you write, like the previous partogram, you write whatever medications you give to the woman during labor, and it is oxytocin. Oxytocin, whether units per liter or drops per minute, and then any other medicine that you give, and the IV fluids if you've given any to her, that you keep on documenting as she progresses in labor. Section 7 is shared decision making. So that is below. You can see there is assessment. First you assess based on all the findings that you have done, and you say, mother is fine, the baby is fine, continue, you're happy with the progress she's making, and you say, continue with the plan. If you're not happy with the baby's progress, you want to change something, you'll plan it here. But you will discuss all this with the woman, and that is why it is called a shared plan. So how do we use? First of all, we assess the well-being of the woman and her baby and the progress of labor. These 3 things make a labor care guide. And then you record, and then you check reference threshold, the alert column, and see whatever observations you've made are within the normal range or not, and then you plan. Okay, but unfortunately in Pakistan, how do we work? Mostly I see this partogram being filled up retrospectively. And once the woman delivers, and we go, because the consultant will ask, so you go back and fill up all these columns. It's not to make it's not used as a decision-making tool at all. So this is a manual, WHO. It is available online. If you Google it, you'll find it. And these are other, tools there which can help you to plan the care of your women in labor. And thank you very much. If you have any questions, I can answer.